I would like to start this session on climate change and health. It is now 12 p.m. in the Eastern Caribbean and 11 a.m. in Jamaica. Regarding this session, the concept note indicated that climate change also has health implications. Warmer temperatures can mean that vector-borne diseases may spread more frequently and also have more frequent occurrences. On the other hand, more extreme wet weather events mean considerations for water quality and mitigation of waterborne diseases. And the panel today comprises three experts in the area of climate change and health. They are Doctors Boodram, and Stewart-Ibarra, and Georgiana Gordon-Strachan. The first presenter today is Dr. Boodram, who is the head of vector-borne diseases at the Caribbean Public Health Agency, CARFA. The agency provides technical cooperation in public health, capacity building, and lab reference services to 26 member states in the Caribbean. Dr. Boodram holds a PhD in biochemistry from the University of the West Indies and an MSc in epidemiology from the London School of Hygiene and Tropical Medicine, University of London. Her primary research interests include genetics of diabetes mellitus and infectious disease epidemiology. She served previously as a molecular biologist at the Caribbean Epidemiology Center, where her work focused on the application of molecular diagnostic tools in the surveillance of public health priority diseases, including HIV and TB, foodborne and vector-borne diseases. Under her vector-borne diseases portfolio, Dr. Boodram works with regional and international stakeholders on various strategies to reduce the morbidity and mortality associated with mosquito-borne diseases. Efforts are focused on strengthening climate-integrated disease, entomological surveillance, improving vector control operations, research and application of new vector control technologies, and promoting community engagement in the fight against vector-borne diseases. Dr. Boodram is not able to be here in person, but she has submitted a video of her presentation. So can you please share Dr. Boodram's presentation? Thank you.
Hello, good day. My name is Dr. Boodram, and I am the head of vector-borne diseases at the Caribbean Public Health Agency. My apologies for not being able to deliver this presentation live. However, I do hope that you enjoy this particular panel segment on climate change and health. Within the Caribbean and in the context of small island developing states, climate change and its effect on human lives, nature, and the general environment cannot be dismissed. We have seen increases in the average annual air temperatures, rises in sea level, more precipitation in some areas, and drought condition in others. Very clearly, an increase in storm frequency and severity. By the end of the century, we expect globally anywhere from 0.5 to 4 degrees Celsius rise in global temperature, further changes in precipitation patterns and rise in sea levels, more severe storms, and continued acidification of oceans. Within the context of Caribbean climate and health, the Caribbean has been experiencing, as described previously, more severe weather events, be they hurricanes, floods, droughts, heat waves, and also Saharan dust incursions. The effects on human health and social development in the Caribbean have been widespread, and they include adverse health outcomes such as respiratory complications, heat-induced morbidity, outbreaks of vector, food, and waterborne diseases, injuries, and fatalities. Caribbean states have limited capacity to respond to these events presently. Thus, the current and future focus for health systems is building climate resilience with the appropriate adaptation and mitigation strategies. Strong links have been demonstrated between climate variables and infectious disease transmission and spread. Some incipient work has begun in the region over the past few years, namely country collaborations with the Caribbean Institute for Meteorology and Hydrology, CARFA, the 5Cs, Red Cross, the Pan American Health Organization, and the UWI, and of course, the Pilot Project for Climate Resilience. These various initiatives are seeking to strengthen interactions between multi-sectoral professionals for the creation and implementation of early warning systems for health. The output will be climate-integrated health tools and services that generate information to support public health decision-making and resource allocation. Early warning systems have been successfully used in many circumstances to increase the lead time before an epidemic occurs, providing time to undertake actions to prevent significant numbers of disease cases. With respect to early warning systems for health, climatic variables and disease data are brought together to improve future health or disease prediction. Over the past few decades, the improved weather forecasting gives opportunity to develop these early warning systems for weather-based events. Models have been developed which apply very well to vector-borne diseases and respiratory illness, and there has been some application with respect to food and waterborne diseases. The diagram on the left shows the relative risk of dengue given climatic exposures and time lags. This data is specific to Barbados. This risk model here was generated using various weather parameters or indices, including sunlight precipitation indices, minimum and maximum temperatures, etc. Applied geographically, these models allow us to highlight areas of high risk and where public health interventions will be required. Within the health sector, two terms are used upon which clarity must be brought. These are surveillance versus early warning. Disease surveillance systems collect and allow us to summarize data. They allow us to detect disease outbreaks as they occur. Early warning systems alerts the population, governing bodies, and various response groups in advance about potential adverse conditions that could lead to a disease outbreak. Surveillance data that's collected feeds into early warning system frameworks, and combined with environmental and climate data allow for robust risk predictions. This caters for implementation of effective measures that can be used to reduce adverse health outcomes. Now let's take a look at some of the elements that go into early warning systems. This slide lists some of the issues with using climate information. The spatial and temporal scale of the critical weather variables need to match well enough with the health data. Appropriate statistical measures need to be applied to the analysis. Sometimes these can be simple correlation, trend analysis, etc. The analysis must be credible, timely, and address key issues raised by decision makers and the public. The analyses should consider all relevant factors that affect the appearance of the disease outbreak, such as location of vulnerable populations, etc. However, note, early warning systems are not contingent on climate information alone. Socioeconomic factors, population demographics, etc. are key factors as well. Early warning systems allow us to predict possible disease outbreaks. The factors that need to be considered are listed. Again, the goal of an early warning system is to develop effective and timely interventions, taking into consideration all factors that can affect the occurrence of an outbreak. Here, we would like to evaluate the potential for epidemic transmission, identify epidemic-prone areas and population at risk to allow rapid prediction and detection of cases, the targeting of the public health response, and the planning of logistics for response. We would like to try to quantify climatic and non-climatic disease risk factors, and also quantify the link between climate variability and disease outbreaks in order to construct these predictive models. There are some very important features to early warning systems. They should be able to provide warning in sufficient time for action. It must be affordable and require minimal skill and training to operate and maintain. Very importantly, they should give minimal false positive or negative responses and should be robust, reproducible, and verifiable. These systems should also be easily modified to address a changing climate, and an effective and timely response plan must be associated with them. And lastly, but certainly not least, there should also be an ongoing evaluation of the system and its varying components. One of the features of an early warning system, as mentioned previously, is the association with an effective response plan. This includes explicit identification of where and when the plan will be implemented, what thresholds will be set for action, what and how specific interventions will be implemented, and to whom the interventions will be communicated. Here we see an example of 3 or 4 major groups involved: the national government, the National Disaster Risk Management Agency, the local government, if that structure exists, the community and other sectoral stakeholders, such as meteorology and hydrology, the geology sector, marine, health, and agriculture sectors. This is an example of how early warnings can result in early actions, looking at different timescales, and an example focusing in on malaria. Now, malaria is very important for our South American CARPHA member states and also Haiti. If we look at monitoring over a period of weeks through direct surveillance, we can see in this example an increased report of malaria outbreaks in a certain area. Apart from direct vector control interventions, the response may be to facilitate access to treatment and to continue sensitizing communities on bed net use. If we look at a time frame of a few months, this is where our early warning system models and forecasts really come into play. The forecasts of enhanced risks of a malaria outbreak in various areas may be based on annual rainfall, temperatures, etc. The associated response is to coordinate with government and agencies on contingency planning, healthcare facility preparation, continue sensitizing communities, and procuring and distributing bed nets. If we increase the time frame to years, we may see a situation where areas are reporting malaria that were previously malaria-free. This could be as a result of rising temperatures and increased inclusion of the vector. Here we look at planning for more long-term prevention and mitigation actions, updating risk maps, building health infrastructure, identifying new vulnerable groups, and continuing with sustained health promotion campaigns. Once the early warning system is implemented, there needs to be ongoing monitoring and evaluation of the system to ensure it's timely and effective. There are some things we need to consider. What are the chances that the system will fail to predict an epidemic? And how many disease cases or fatalities could occur? What are the chances of sounding a false alarm, thereby wasting resources and undermining public trust? Is the system really as responsive as needed? How could disease incidents or the number of new cases be reduced or lives saved if the system response was faster? And lastly, very importantly, is the system cost-effective and sustainable? Now, shifting gears a little, under the pilot project for climate resilience, CARPHA is responsible for subcomponent 4.1, which reflects early warning systems and health. CARPHA is the implementing agency, and the consulting team hired to assist in this effort is the Inter-American Institute for Global Research, or IAI. The beneficiary countries for this particular activity are St. Lucia, Jamaica, and Haiti. And under this particular subcomponent, there are 3 aspects: development of a regional health order tool for vector-borne diseases, development of an early warning system for vector-borne diseases, and lastly, a gender and vector-borne disease study within the communities. With respect to the regional health audit tool, a comprehensive country baseline assessment tool was developed to carry out a risk assessment for vector-borne diseases. The consulting team carried out that work in the last quarter of 2019, and several different stakeholders were engaged from the health and meteorology sector. Under health, we had partners from the epidemiology, environmental health, and the entomology and vector control units, and then, of course, the meteorological services. Now, the tool that was developed took into account the input from these various stakeholders, and it supports climate-integrated vector-borne disease surveillance, effectively a gap analysis of that system. This tool was developed so that when we actually went to do the assessment and gathered the relevant information, it would lay the foundation for planning of the early warning system for vector-borne disease, which is developed under this particular project. Now, this early warning system involves the creation of spatial temporal tools or model outputs that are able to describe arboviral risk and forecast arboviral patterns. Out of the 3 PPCR countries, Jamaica and St. Lucia have been engaged thus far, and the work is expected to be carried out between Q2 to Q3 of 2021. The methodology focuses on the collaborative co-creation process with the country stakeholders to ensure usability and sustainability. It will involve data acquisition, cleaning of data, database establishment for various areas such as epidemiology, entomology. We will be able to conduct training workshops and implement and evaluate the tools in question. Recommendations will be developed for future sustainability. In terms of lessons learned from early warning systems, we know that early action can save lives. Climate, however, is only one of the many determinants that must be factored into these systems. The early warning of a crisis, however, is no guarantee of preventing or averting that particular crisis. Stakeholders must have the relevant capacities and willingness to respond to these particular incidents. Just want to say thank you for your time and attention, and I do hope that you enjoy the remainder of the session.
Thank you very much, Dr. Boodram, for your presentation where you looked at early warning and surveillance systems for diseases in response to climate change threats. Okay, well, before I even go into the next presentation, I forgot to introduce myself. I am Donald Simeon. I am from the University of the West Indies, St. Augustine campus, where I'm the director of the Caribbean Center for Health Systems Research and Development. I'm also professor of biostatistics in the Faculty of Medical Sciences. I also should indicate that folks should, or the persons who are attending, the attendees should post any questions you have in the chat, because the format of this session is 10 minutes each for the presenters, for the panelists, and then 10 minutes of discussion in which questions can be addressed. The second panelist of this session is Dr. Anna Stewart-Ibarra, who is the scientific director of the Inter-American Institute for Global Change Research, the IAI, an intergovernmental organization based in Montevideo, Uruguay. She was formerly the director of the Latin America and Caribbean Research Program of the Institute for Global Health and Translational Science at the State University of New York, Upstate Medical University, SUNY UMU, from 2012 to 2019. She is also an assistant professor in the Department of Medicine at SUNY UMU. Dr. Stewart-Ibarra's research focuses on understanding climate, environment, and social drivers of vector-borne diseases and other dimensions of human well-being in Latin America and the Caribbean. For more than 13 years, she has collaborated with academic and government institutions in the region to conduct community-based social, ecological, epidemiological, and modeling studies. These studies aim to inform the development of climate services for the health sector, community health interventions, and novel vector control tools. She received a PhD in ecology from SUNY College of Environmental Science and Forestry and a master's in public administration from the Maxwell School of Citizenship and Public Affairs at Syracuse University. Honors and fellowship includes Fulbright in Argentina and Ecuador, the Prometeo Fellowship of Ecuador, an Emerging Public Policy Leader Award in the American Institute of Biological Sciences. I would like to invite Dr. Stewart-Ibarra to start your presentation, please.
Thank you, Dr. Simeon, for that very kind introduction, and thank you for the organizers of this meeting for the opportunity to participate. I'm going to share my screen now, and please let me know if you can see it. Does that look okay?
Yes, we can see it.
Great, thank you so much. So today I'll be speaking, following up on that fantastic presentation by Dr. Boodram. I'll be speaking about building resilience to mosquito-borne diseases in the Caribbean, and really providing some more details and focusing on, again, the vector-borne diseases. So arboviral diseases transmitted by the Aedes aegypti mosquito, like dengue fever, Zika, and chikungunya, are a public health priority in the Caribbean region and really across the tropics and subtropics worldwide. So even before the COVID-19 pandemic began, many countries were struggling to control outbreaks of dengue. Record cases were reported in recent years. You can see here the report from the WHO with cases in 2019 and 2020. And public health interventions that were initiated to halt COVID-19 have affected routine vector surveillance and control activities throughout the region. So this is a major challenge that we are facing today. Mosquitoes are largely affected by ambient air temperatures because they can't control directly their internal body temperature. Many of their life history traits respond to temperature, such as lifespan or biting rates. Thanks to work led by Erin Mordecai at Stanford, we now know that there's a range of possible transmission of arboviruses from 18 to 34 degrees Celsius, and a range of optimum, here's the possible transmission, and optimum transmission from 26 to 29 degrees. And this is when we're considering both Aedes albopictus and Aedes aegypti. In the Caribbean region, Aedes aegypti is definitely the dominant mosquito vector. And that's because you can see here that Aedes aegypti prefers slightly warmer temperatures, which is why it's a more effective vector in the Caribbean region. Well, rainfall is a bit more complicated. We've seen that both heavy rainfall and drought can increase mosquito larval habitat. Rainfall can create standing water in rubbish around the patio, and drought conditions often lead people to store water around the home. Actually, in work that we did in Barbados, we found that drought conditions followed by heavy rainfall increase the likelihood of dengue outbreaks, and I will mention that later in the presentation. Since 2019, our team has been working with the PPCR program and regional and climate and health authorities, and our work has been focused on supporting key adaptation initiatives to enhance resilience to vector-borne diseases, which I'll speak more about. And I should mention that the work that I will be sharing is representative of, again, a team of investigators from the University of Florida, the London School of Hygiene and Tropical Medicine, SUNY Upstate Medical University, and Walking Palms Global Health, among others, also CIMH. So what can we do to adapt to changing climate conditions? Well, early warning systems, or climate services for the health sector more broadly, provide a promising adaptation strategy. Climate services for health is an emerging field of applied science. It brings together multi-sectoral professionals to co-create tools and services to better understand and take advantage of the influence of climate and weather on health outcomes, like epidemics of infectious diseases. Climate services for health use high-quality, tailored climate information to help decision makers in the health sector better understand the effect of extreme weather and climate change on disease transmission and spread. This information, combined with a prediction framework, can allow us to anticipate when, where, and who may be at risk of diseases. And you can see here this quote from an interviewee in the health sector in the Caribbean, and they said, if we can put mechanisms in place long in advance, then we have more success in dealing with outbreaks, or we could even prevent outbreaks. And on the right side, you'll see resources that I've highlighted. These are all openly available and online for those who want to learn more about climate services for the health sector. So what is being done in the Caribbean region? Well, the Caribbean region is really a leader in the area of climate services for health. The Caribbean Health Climatic Bulletin is one of the best examples of an operational climate service for the health sector. This bulletin is issued quarterly by regional climate and health authorities and provides key messages on different aspects of health, And you can see here the most recent bulletin, and I've extracted some of the messages related to vector-borne disease and COVID and climate impacts. And these are available on the CIMH website. Another example that Dr. Boodram mentioned is the development of early warning systems. This is one of the areas that is, I would say, being most developed in climate services for health. Here is an example of a vector-borne disease decision support system. And on the left, you can see different data streams that enter these models. So for example, we have epidemiological data, entomological data, climate and weather data, and underlying spatial information about the environment and social conditions. This information comes together in different types of statistical or mathematical models. And the output of these models are tools for the health sector, like maps, tables, graphs, etc. Really important to note, and Dr. Boodram mentioned this as well, is the co-development process. Co-development means that partners work together to develop the climate service through an iterative and dynamic process. As indicated in the diagram, these models or tools are part of a social process. We have partners from the health sector, the climate sector, and others, for example, disaster management, perhaps water authorities, and academic sector. This adaptive modeling process spans from the definition of the problem through the implementation of the actions by the health sector, and the outcomes at each step shape the prior steps of the process. An example of a climate service in the Caribbean is the pilot early warning tool for dengue that has been developed for Barbados. This was developed in the program on building regional climate capacity in the Caribbean, the BRCCC program led by CIMH. This work began in 2017, and this collaboration continues today. This study focused on exploring whether dengue outbreaks could be predicted using temperature and a precipitation index. And we found that the model successfully predicted months with dengue outbreaks versus months that did not have outbreaks in most years from 1999 to 2016. We also found that the risk of dengue outbreaks increased with increasing minimum temperature up to 25 degrees Celsius, and outbreaks were more likely 4 to 5 months after periods of drought and 1 month after a period of excessive rainfall. The key health message here: drought periods followed by intense rainfall 4 to 5 months later could provide optimum conditions for an imminent dengue outbreak. Of note, as Dr. Boodram mentioned as well, dengue outbreaks depend on more than just climate conditions. So certainly this information will be taken into account in a broader context, considering, for example, the serotypes of dengue virus that are circulating in the region, ongoing vector control interventions, and other relevant information that would affect disease transmission. Under the PPCR program, again, we began this work in 2019. This dengue forecast model is now being adapted for the PPCR pilot countries. Co-development is ongoing with national stakeholders. As Dr. Boodram mentioned, a data audit was completed in 2019 to identify climate epidemiological and entomological data available for the model. We are also investigating the role of gender in arbovirus control and disease transmission to support mainstreaming of gender and gender considerations in adaptation actions. We will be holding some training workshops this month and again later in September. So this is really what I think is, to me, the most interesting part of this discussion. I hope we'll have more time to discuss this in the session: opportunities and challenges. First, the key area of opportunities and challenges I see is policy and partnerships. How do we engage senior leaders to raise the issue of climate and health on the agenda and to ensure that resources are allocated to support this work? We need to create national mandates so that the health sector is able to address climate impacts, and this does not exist in many countries. Formal collaboration agreements are critical. CARFA and CIMH signed MOUs in 2017 and played a key role in leadership for the region, supporting work now at national levels. And so at national levels, signing collaboration agreements will be important next steps. In meetings like today, we create joint spaces of dialogue, listening, and training for climate and health sector and other relevant stakeholders. As I mentioned before, this co-development process is critical to build relationships and trust, and this is a long-term process of engagement. A key opportunity is in the area of implementation science. This is an emerging field that addresses the knowledge to action gap and can help us to scale up adaptation measures. The next area are data that I want to mention. So climate and health data collection, harmonization, and sharing protocols need to be developed. We can think about how to strengthen integrated climate and health surveillance systems, and how can we use Earth observation data to fill gaps in local information. Lastly, I'll mention training. In previous work that we did with stakeholders, the health sector stakeholders in the Caribbean indicated to us the need to strengthen certain areas, including skills in GIS, modeling and data analysis, data collection, and storage practices. So I'll just finish mentioning a few upcoming training and funding opportunities hosted by my organization, the IAI. Again, as mentioned by Dr. Simeon, we are an intergovernmental organization with parties in Latin America and the Caribbean, and actually through all of the Americas and the Caribbean. We will be hosting regional training workshops focused on transdisciplinary science for climate, environment, and health later this year. We are working with the Belmont Forum, a consortium of 31 funding agencies, science funding agencies, to issue a collaborative research action on climate, environment, and health, and that will be issued next year. And prior to that, we will be hosting scoping workshops to identify priorities. And so this is an opportunity for experts, funders, and policy stakeholders to be involved in shaping that call for grants. We will be developing professional development seminars on transdisciplinary science and science diplomacy for this year and the coming years. We will have seed grants associated with that to support regional science networks. And there is a science, technology, and policy fellowship program known as STEP that was launched in the last year and is growing. It's another opportunity. And lastly, I'll mention the PAHO WHO virtual open access course on climate information for the health sector that is under development and will hopefully be launched in the coming year. I'll finish that and leave these additional publications for those who want to learn more about our work. And I thank you again for the opportunity to participate in this fantastic panel.
Excellent. Thanks for that brilliant presentation, Dr. Stewart-Ibarra. We really enjoyed hearing about the exciting research that you are doing. Congratulations. Moving on with the panel, the third panelist is Dr. Georgiana Gordon-Strachan, who folks may realize is one of the main organizers of this conference. So I will use this opportunity to really congratulate Dr. Gordon-Strachan and her colleagues on this very timely and an important conference, which has already made a big impact on a number of key stakeholders. And of course, we look forward to the outcome of it beyond today, because the conference ends today. In terms of an introduction for Dr. Gordon-Strachan, who holds a PhD in biochemistry from the University of the West Indies and an MSc in health policy planning and financing from the London School of Hygiene and Tropical Medicine, University of London. Her research interests span reproductive health, teen pregnancy, climate change and health, in injuries and violence, youth risk and resilience behavior, healthcare financing, reproductive health, maternal and child health, and chronic non-communicable diseases. Well, quite a wide range of interests. Excellent, Dr. Gordon-Strachan. She has co-authored 65 publications in peer-reviewed scientific journals, 2 books, 3 book chapters, and 40 abstracts in scientific conference proceedings. She is a former director of the epidemiological research and data analysis at the Ministry of Health, Jamaica, and a former director of the Mona Office for Research and Innovation of the UWI in Mona. She is currently employed to the Caribbean Institute for Health Research as a senior lecturer. Dr. Gordon-Strachan, please.
Thank you, Professor Simeon. Thank you. I'm just going to try to share my screen.
Yes, we can see it.
Okay, all right, thank you so much. All right, so good morning, everybody, and thank you so much for joining us, and thank you for making this conference the success that it has been. We couldn't do it without you. My presentation today is on climate change and health. And I am not going to use the usual suspects. I'm going to talk a little bit about extreme heat, and I'm going to look at heat stress and its relationship to labor capacity and sports. So let's start with a few definitions. So what is heat stress? Heat stress actually occurs when the body is unable to cool itself and regulate a healthy body temperature. The increase in heat in temperature outside causes our inner core, the temperature of our inner core in our bodies to rise. And this actually causes blood to be diverted from our internal organs to our skin for cooling. This results in an increase in our heart rate and can worsen existing conditions. So manifestations of heat stress are losing concentration, fainting, and in extreme cases, death and disability. Heat stress may be caused by external factors such as high temperature, high humidity, and strenuous exercise. I wanted to bring your attention to this publication, which just came out on the 31st of May, 2021, and it's a publication from Nature, and it was looking at heat-related mortality or heat-related deaths, which are attributable to recent human-induced climate change. So just to give you an idea of what they did very quickly, they used empirical data from 732 locations in 43 countries. And what they found was that 37% of all heat-related deaths could be attributed to anthropogenic climate change. So for our Caribbean, the climate projection is that one climate projection is that it's going to be hotter and drier. And Dr. Boodram alluded to this earlier. So who will be affected by heat stress? Who are the vulnerable people? The elderly, the pregnant, the disabled, children, manual workers who work outside mostly, and of course our athletes. So my presentation is going to focus on athletes and manual workers. So I'll start with manual workers by talking about labor capacity. And I'm going to be presenting very briefly an assessment of labor capacity in Jamaica using future climate projections for RCP 2.6, which is a best case scenario, and RCP 8.5, which is a worst case scenario. So just so that we're all on the same page, I'm going to tell you what labor capacity is and how it relates to heat stress. Labor capacity is actually defined as a working time required to safely perform sustained labor under environmental stress, environmental heat stress. It's measured as a percentage of standard labor, and standard labor is 8 hours per day under normal conditions. And it is, so for labor capacity of 100%, it would be somebody working for 8 hours for the day without heat stress. So we worked out labor capacity. We estimated it by using a technique called wet bulb global temperature. And you'll forgive me for using the acronym WBGT as we go along, because it's a little bit of a tongue twister. So because there were no standards for Jamaica, we use a Chinese standards for different manual workers, and we related it to a WBGT. And this was actually done before by a researcher called Liu. We used workload 4, which relates to heavy manual labor, and we looked at the threshold for labor capacity of 75%. So what that means is that instead of working for 8 hours, because the heat is so extreme, you can only work for 75% of the day, or that would relate to 6 hours. So we calculated the WBGT, and we used the average monthly WBGT that we calculated. We compared it, we calculated it for a reference period of 1995 to 2003, and then for the projected climate period by decade from 2020 to 2099. We then selected the months with WBGT greater than or equal to 26, as this relates to our 75% labor capacity cut point. So I know that this is a bit of a busy slide, but I really just want to show you 2 things in it. The first is that when we look at the best case scenario, which is RCP 2.6, and we look at it over time by month, so this is January, February, March, April, May, and so on, and we compare 1995 to 2003, which is our reference period, with the other decades, what we find is that for 1995 to 2003, we only had 3 months for which the average WBGT was greater than or equal to 26. Now compare that with the other decades. The first thing that you will see is that there's a seasonal pattern. So in other words, these are the cooler months from January to May. Between June and November, there is an increase in the number of months with average WBGT greater than 26%, or a reduced work capacity of 75%. Now let's look at the worst case scenario. And immediately what jumps out at you is that this seasonal pattern, which we saw for 2.6, does not prevail for 8.5. As a matter of fact, by the time we get to 2050 to 2059, we're starting to see that our labor capacity is being reduced by at least 75%. So let's have a look then at global warming, heat stress, and sports. Just to make a general statement that all major sports are affected by climate change, and this is especially so for extreme heat. Now, I know those of you from the Caribbean will know this picture. It's when we won the ICC 2019, and the ICC is a cricket tournament, and cricket is actually our game. It binds us as a Caribbean people, and we have a West Indies cricket team. Cricket is played over, there are 3 different formats, but basically the two of those formats, one lasts for days, the game lasts for days, and the game lasts for about 1 day. There's another format called the 2020 where the game lasts for about 4 hours. Within the cricket fraternity, there is a very important series called the Ashes series, and this is played between England and Australia, and they compete for the Ashes. And in the Ashes series of 2018, England's captain had to be hospitalized during one of the test matches because of heat exhaustion. On that day, the cricket grounds in Sydney was 57 degrees Celsius. Now, because of that, cricket has adopted an extreme heat policy, and the umpires are authorized to stop play if the heat becomes extreme. Now, this has led to the cancellation of cricket games and threatens the test and one-day formats of the game. Now, let's look at tennis. The US Open of 2018 was also quite hot. Djokovic and 4 other players retired from the tournament because of extreme heat. Since then, both the Australian Open and the US Open have implemented what we call heat rules to protect the players, the umpires, and the ball boys or ball girls. Football is not immune to this, and World Cup football of 2014 was the first time that the game had to be stopped to ensure that there were cooling breaks for the players. And this is a game between Mexico and the Netherlands. So what does that mean for us? The first thing it means for us is if we accept that we're going to have a hotter climate, hotter, drier climate, then we need to be able to do something about it. We tend to think that because we live in a tropical climate where it's already hot, we're acclimatized, so it doesn't affect us. But we need to remember that these are unprecedented times. So the first thing I think we need to do is to really beef up our surveillance as it relates to heat stress. So I'm suggesting that we set up surveillance systems for monitoring extreme heat and heat stress, and also developing early warning systems for the public so that they can relate the increasing temperatures to exposure to heat. I would also like us to include relative humidity in our weather reports so that we can actually calculate our WBGT. At the moment, it's not necessarily reported on for all countries. So for labor capacity, we can expect a reduced work capacity for manual workers, especially those who work outside. For this, we will need to revise our occupational health and safety laws and guidelines to ensure that our workers are protected. So we can include things like cooling breaks, we can hold work, or we can probably stagger work hours. We also need to educate the public, especially the farmers who work outside most of the time, on recognizing signs and symptoms of heat stress and to advise them on when they need to take cooling breaks. The public also needs to be warned, and this should be done by first educating them on the impact of heat stress. Now, workers are disproportionately affected by this, especially manual workers, because they are usually paid on an hourly scale, and if our projections are correct, they will have less working hours and will therefore get less pay. The unfortunate thing about this is that quite a few of these workers are also minimum wage earners. For sports, we need to prepare or at least adopt guidelines for heat rules in our Caribbean sports. We need to expand these guidelines to all outdoor sports, and we need to educate our athletes while they're training and while they're competing to understand heat stress and to learn about how to prevent it. For me, this short presentation brings to mind the fact that we need to innovate. One question that comes to me always is, how can we create new ways to protect ourselves from heat stress in this predicted hotter and drier future? We already have climate-cool clothes, but there are many other interventions and innovations which can emanate from this problem. One, I think that's really, really important, and I think this will affect all of us, is investment in innovations which look at cheap but effective cooling devices, which of course will have zero or no carbon emissions. These are my thoughts, ladies and gentlemen. Thank you so much for listening.
Thank you very much, Dr. Gordon-Strachan, for that excellent presentation. I really like how you brought in, the impact of climate change on health regarding sports and, of course, recreation, which is so important to us in the Caribbean. Thanks so very much. I am looking at the time, and I'm seeing that the closing plenary starts in less than 2 minutes. So I'm not sure if we'll be able to take any questions, perhaps not. So I'd like to thank, of course, the 3 panelists, Dr. Boodram, Dr. Stewart-Ibarra, and Dr. Gordon-Strachan, for your excellent presentations. I noted, though, that there were a couple of questions in the Q&A which were responded to by Dr. Stewart-Ibarra. So thanks very much, Dr. Stewart-Ibarra. And of course, I invite everybody to click on the program, on the agenda, to join the plenary closing session. Thanks again, everybody, and enjoy the rest of the conference. Goodbye.